We're now ready to move into our last panel, which is the discussion on physicians and hospitals, new collaborations to combat chronic disease. I think most of you in this room are healthcare professionals, so you're aware of the changes that hospitals are going to be under to deal with provisions of the ACA. So continuing with our theme of how ready is New Jersey for this, and to talk about the ways that physicians and hospitals are really changing age-old practices. Jim Roberts, our moderator, is a partner with McElroy Deutsch Mulvaney and Carpenter LLP, noted healthcare attorney. Our other panelists, Skip Semino, our host, you've heard from before. Dr. Kenneth Sable, who's with St. Peter's. He brings the unique perspective of being both an MD and a COO, so he can give us both the physician-hospital perspective. And Dr. Mary Campanolo, who is Chief of Family Medicine at Virtual Memorial Hospital and also President of the Medical Society of New Jersey. So welcome, and Jim, I'll turn it over to you.
Can everybody hear me? Okay. Well, to start off, and trying to pump a little bit today, I took a stroll down memory lane, and I just want you to come with me for a second. I went to the Reinhardt Commission report, issued in 2008, and I just want to read a couple of the observations that the report made back in 2008 about the relationships between hospitals and physicians. Okay, here, number one, hospitals and physicians do not operate on a common or compatible set of practice-oriented and financial concerns with respect to medical management of patients and the provision of inpatient services. Ouch. Number two, ambulatory care facilities have created new economic challenges for hospitals. These centers, generally owned by physicians, are in competition with the hospitals that are not subject to the same regulatory requirements that hospitals are. Three, physicians face little accountability for consumption of hospital resources. Four, hospital costs are generally unknown to the providers and patients. Five, despite all that, there are many opportunities for improvement, and what the Reinhardt Commission was recommending was, let's focus on practice extenders, let's implement alternative physician staffing models to facilitate more efficient and high-quality care. And then finally, there are no financial incentives to coordinate care or ensure patients have access to continued care once they leave the hospital. Pretty tough medicine there from the Reinhardt Commission. Now, flash forward. We're 5 years down the road. The Affordable Care Act was passed. We're in implementation phase. And the ACA is supposed to change all those things. It's supposed to really try to change that. And the panel here is where the rubber meets the road, in my opinion. We've got the hospitals, we've got the doctors. If we work together, maybe this thing can work. If we work together quickly, maybe it can work quickly. So my question to the panel is that what are you doing, what are your institutions doing, and what is the state of New Jersey, in your opinion, doing to foster the principles and the goals of the ACA? And that is increased primary care, better coordination of care, use of evidence-based medicine, and health information technology. So I'll throw it out. Skip, why don't you try?
Well, thank you, Jim, and appreciate the opportunity to be here on the panel this morning, because when you look at the Affordable Care Act, I think, as was indicated by the original panel, this is an extraordinary opportunity for us to repair some of the issues that exist in healthcare. And it is very true that for a very substantive period of time, probably for all of time, that the incentives between physicians and hospitals have been misaligned. I would also suggest to you that by virtue of the work that is occurring in the Center for Medicare and Medicaid, as well as in our own individual health systems and individual hospitals, that a lot of that is changing. And so as I came into my role back in 2009 in dealing with a number of physicians And New Jersey is replete with ones and twos, and I think that the doctor can certainly talk to that in terms of the extent of the medical community. But many of them wanted no parts of talking about how do we gather in alignment. I'm going to be independent. I'm going to continue to go on my own. Fast forward to 2012 and now 2013, where I have physicians coming in and saying, how can we work together? How can we make the system better? Additionally, there have been other clinical tools that have been provided to us. The Healthcare Advisory Board puts out an excellent tool called the Crimson Clinical Tool. And by virtue of that tool, we can measure resource utilization and length of stay, two very big cost drivers as it relates to healthcare within a hospital. When we bring in the physicians to show them what their results are, my view of the physician community is they are our partners in the delivery of care. And in being partners, they are also highly competitive individuals. They had to be to get where they are in life because of the extensive nature of their education to be able to be there. And when you show them the results, they actually will sit there and say, well, geez, I can improve that. Here's how I can improve it. So that's a very, very significant tool that we have. Another very big tool for us has been to enter into a gain sharing program that Horizon has put forward. And our initial thought was at Hamilton that we would sign up 10 physicians. Candidly, we signed up 45 in the first round. And that has done a substantive process for us of managing and directing the care, and now with the CMS bundled payment model, that's happening. So while it's all not here today, I do think that we are on the right path in terms of aligning the incentives between physicians and hospitals as we move forward in the future.
That was always the issue, right? DRG system and fee-for-service physician reimbursement.
Good morning, everyone. Thanks for having me on the panel as well. Speak up. Okay. From my standpoint as both a physician and a COO, I think this is the infancy. We're just at the beginning of this journey. And how we're going to get there, I think, is anybody's guess. But the process has started. Physicians, traditionally culture is we're in a siloed organization. Physicians in emergency medicine, and I'm one of them, do things very differently than physicians in cardiology and surgery and so forth. And getting people to realize that their work affects the entire enterprise of healthcare delivery is critical to changing any system practices. Skip talks about the gain sharing initiative, and we're right on board with that as well with the CMMI, which is the governmental program. And part of the challenges that I see are physicians, they yearn for the information, they want to be part of it, but there's so many unknowns that when we sit down with them, how is this going to affect us? What is the formula going to look like? How is this going to affect my income? How is this going to affect how I take care of patients? What is the work of this doctor down the line going to do that might affect my interaction with the patient and or the care that I deliver, and, oh yes, how I get paid for it? My background is actually in computer science and engineering before I went into medicine, and I see health IT as pivotal to this entire success or failure of the program. And with the high-tech money, I think that was the beginning, that was the first step towards getting things moving in the right direction. But as we've seen, and most of you are familiar with the big vendors out there, the vendors took advantage and made all the money, and the consultants made all the money on implementing. But at the end of the day, just because a vendor has one name over 10 different products, the buzzword is interoperability. There's no interoperability out there so that a doctor in his or her private office can interact in a reliable way to know what happened down the street at a different hospital versus even a different part of the country. As an emergency physician, I can tell you how many times patients come to the hospital and they said, I was just at another hospital last week, I had a CAT scan, I had blood tests, I had this, and I say, well, I don't have it, so I got to redo it all. And the amount of cost that we spend in just duplicating work because we can't share information is just taxing the system unbelievably. I think as far as physicians and hospitals getting together, there's two different cultures of physicians. There's the older school physicians who are really, get used to their independence, they're used to the way they practice, somewhat resistant to change. And you have a whole different generation coming out who are more interested in shift work, they're not interested in building these primary practices the way they did in the past. And they're probably much more amenable to the system, which is a good thing. But we still have a ton of physicians who've been practicing for 30 years that need to be in this as well if we're to make it successful.
It really is a marriage. I mean, the hospitals and the doctors have to be married to each other. I don't think we're there yet, though. I mean, Dr. Kavanaugh, what do you think about the future there?
Yeah, and I think we have I'm wearing a couple of hats here. So on the medical side of New Jersey front, what we've really tried to do over the past couple of years has been really educate our physicians. You know, as Skip said in the beginning, so many New Jersey physicians are in solo or small practices. And but over the past few years, we have seen a significant shift to moving towards employment, whether with large groups formation around the state or through health systems forming groups of physicians. And so the Medical Society has been shifting to educate doctors about the opportunities and the need to look at joining together and looking at how they partner with other types of clinicians and hospitals. And also looking at how do we develop our member services to serve the large groups, because there probably are many different services that are a little bit different. And so those of you who are hospital people who have employed physicians, I would encourage you all to talk to us about joining your physicians as a group with us. Because there are many services, I think, that hospitals start to find they need that practices have been using for years, but the health systems don't always have those things in place. So that's some of our role right now. The other thing, just to touch on the IT, because I think that health information technology is again, a huge connector for us potentially if it's done properly. And so one thing we're doing as a medical society is an initiative called DocBook MD, which is a secure messaging system. And right now we can get all of our members on our handhelds, be able to find pharmacies and connect with each other and send secure messages and pictures about patients that might, have a clinical challenge that we're trying to get some assistance with. So that's something we've been pushing for our members now, and just recently went through an upgrade where physicians can also set up their own little circle of communication, so that for their team at the practice with a nurse practitioner and an MA, other physicians, they can communicate securely. A lot of people are doing texting, which really is not HIPAA compliant, and that's going to get some of us in trouble one day. So that's what we're trying to get that message out too, that we really need to look at other ways to do that. So that's one service we're bringing. We want to see that expand as we bring on larger groups and doctors begin to work more in teams. So that's where I see, I think, the other issues that we were just hearing about in the Medicaid arena. I think we're also trying to engage our doctors and illustrate to them how it's important to learn to work in teams of clinicians, so that it's not the doctor having to take on all the responsibility to do everything, but that they can learn to delegate. And that's tough. The doctors, as you're saying, a very competitive group. They want to be the best, and but they need to learn, I think, also how do we distribute some of the care and be able to serve more people that way. So that's something else we're training our doctors in. And also this year, there's been a really, I think, exciting development within the state, is that we've participated with a group of multi-stakeholders between the Medical Society of New Jersey, the New Jersey Hospital Association, Jersey Association of Health Plans, and Rethink Health is the name of the group. And it's Linda Schwimmer has been working with us on that as well through the Ripple Foundation, which has been a convener of that group. So I think that's going to be a way where we're trying to bring people together to build trust, which is, I think, one thing we've been needing in New Jersey is trust among those different groups of the healthcare arena.
The other thing we need in New Jersey are more primary care doctors. We know there's a shortage of primary care doctors. And the ACA is going to help with that because there's going to be more money for primary care. But, there's a real face-off now, I think, not face-off, but really an issue that has to be grappled with in terms of what is a hospital-centric, or what was a hospital-centric healthcare system. You got sick, your doctor admitted you to the hospital, you got better, and you left. And that's how many people have gotten their care over the years. Now, the goal is going to be to keep patients out of the hospital, keep them healthy and out. Now that's a little bit financially adverse to what the hospitals are used to and what they've developed, the kind of reimbursement that they've developed around. What are the hospitals doing in order to prepare for that, primary care focus, keep the patient out of the hospital scenario?
So can I put on my other hat now?
Sure, put on your
So now, the work that we've been doing through Virtua Health has been, our tagline or our mission right now is be well, get well, stay well. And so, and actually over the course of the year, as a physician looking at it, I think it's been remarkable that we're really taking a focus on the future being population health. And so we've changed the number of the titles for the different administrators in the organization to Vice President for Population Health and Clinical Integration, for example. And so I think, again, we're working, it's a lot of change, I think, and we are working towards a model where we have Virtua Medical Group, which is started primarily as primary care groups that join together, and we've developed the information services to support them. We're pretty close to rolling out our health information exchange, which will serve the purposes of what the doctor was talking about reducing rework and sharing information. And then we're also, recognized medical homes for 14 of the sites that we have, and as well as the organization, and building the layers of team on top of that at this point. So it is a tension, though, I think, and we have to figure out the financial model isn't quite there yet. And we have to, I think any health system has to figure out where's the tipping point, and where is it that we can start to make more on the value-based care as opposed to the volume-based. And so I think we're in this difficult position because we're kind of we're building the systems to support the future, but we have to continue to work in the current economic situation.
Well, I think Mary hits on a very, very essential point here, and that is that the shift for hospitals is not in a fee-for-service mode any longer. It's going to be about outcomes. And by virtue of the Affordable Care Act and by virtue of what the CMS is doing, we need to be more focused on outcomes. And if we fail to be focused on those outcomes, we're going to pay a cost for that. And it's very, very essential that we look at those and understand what the values are that we need to provide. Additionally, I think that hospitals, in large measure, Virtua, we're fortunate to be part of the Robert Wood Johnson Health System, are moving more and more ambulatory strategies out of the hospital. We are, in fact, engaged strategically in where will we place other boxes. This indeed is a box here that we built 10 years ago as a Center for Health and Wellness. When you look at the Affordable Care Act, what's fundamental to the Affordable Care Act is prevention and wellness. And so getting people in the beginning, that's not to say that hospitals won't participate and have centers that will be profitable for them. They will, in fact, have those centers. But moving from a situation where it's fee-for-service and to outcomes-based dialogue is going to be essential for the inpatient aspect of healthcare. And then having ambulatory sites and centers for health and wellness that talk about prevention and talk about wellness are going to also be essential. And that's a real behavioral shift. That's not going to happen in 2013 and 14. This is going to, as the initial panel said, this is going to take an expanse of time for that to happen. Hopefully, the general public will understand that that's what has to happen and that they will come along. We have a tendency in our country to want things instantaneously versus understanding we're shifting 20% of our gross domestic product here, and it can't happen in 2 years.
No question, it's a seismic shift. I mean, and it's going to take time. People have to be patient, and it's going to have bumps in the road. Ken?
I just wanted to add, to your point about instant gratification, on the other hand of the emergency physician side, I've been the beneficiary of rising emergency department visits for the past decade plus. And we all know the 100+ million visits and rising. That was largely because of an access issue, as we all know. But the secondary effects of that are we became very efficient in the emergency department at delivering care acutely, quickly, and giving patients instant gratification. So we have to be careful that patients who currently, the culture is, you know, you go to the emergency department, although everyone is upset if they have to wait a few hours to get their care done. The bottom line is you can have a CAT scan, you can have all your blood tests, you can get a prescription and medication within 4 to 6 hours and you're out of there. Fast forward to a primary care infrastructure that may not be, even though there may be more access, people are accustomed to having this instant gratification. So we have to be prepared for that paradigm shift, that as we transition patients to more primary care outpatient facilities, they won't be 24/7. I mean, they can't be just based on the cost alone. And I'm into buzzwords, as you probably heard already, but care coordination is the buzzword. What Skip and Mary talked about, what they're doing in their individual institutions, is exactly what I'm doing at St. Peter's, and strategically looking where do we place our footprint, our black boxes of access to care. You know, one of the things we participated in recently was the Robert Wood Johnson Foundation Community Assessment Grant, which I know many hospitals have teamed up to do in different localizations. We have found very specifically areas around obesity, childhood obesity, diabetes, mental health, and these are going to actually not only just become pillars for us to focus on, but they're actually going to be tied to reimbursement. We used to get charity care, if you will, the healthcare subsidy fund that would basically, as we told them this is what we did, we would get paid. Now they're tying that to outcomes as well, something called DSRIP, which is now going to, and the specifics are still a little bit up in the air, but essentially we're going to have to choose a particular area to focus on, and not only that, demonstrate outcomes in order to get the money that we're saying we should be getting for the charity and other care we're providing to our community. So the stakes are really high, obviously millions of dollars at stake for every hospital, and we have to get this right, and we have to start coordinating better to make this happen. In order to do that, it requires an infrastructure. Care coordination is an infrastructure. When I'm an emergency physician and I discharge a patient and I never know what happens to them after they leave, that's not acceptable in the new paradigm of what we're going to be entering into.
Yeah, you know, it's interesting. There are all going to be all kinds of new reimbursement, terms that we'll hear. Bundled payments, pay for performance, or value-based purchasing, those kinds of concepts. It all boils down to trying to do the right thing, trying to provide the right level of care at the right time. It's a geographical thing in a lot of ways. You got your doctors who are close to your facility and the employers around your hospital. I was on a panel about a year ago with Dr. Jeff Brenner down in Camden. And Jeff is a very interesting guy to listen to because he does have a view of the world. And his view is if you focus on the 1%, really, the very sick people with chronic conditions, multiple conditions, who fall through the cracks, who come to the emergency room for their care usually, and just focus on providing good care to that 1%, you will save money left and right. And probably most of the money, most of the savings is right there in that 1%. And you know what he's doing down in Camden. And he's very adamant about it. And I was just wondering what your hospitals are doing, if at all, to focus on that 1%. I know you are, but what are you doing to focus on that 1% to try to get to the cost that resides in that sliver?
I can say a few words about that. Traditionally, the initial diagnoses that would be targeted are acute MI, a heart attack, pneumonia, and congestive heart failure tend to be some of the higher costs of care for chronic disease. One of the things, and doing things that we're kind of being forced to by the regulations and the payments that are tied to it, the readmission rates is one that very looked at closely in terms of patients who come to your hospital, they get care, and then they come back to the hospital. Or they come back to another hospital and get admitted, either for the same condition or a different condition. And finally, I think appropriately so, I may disagree on some of the specifics of it, but at the end of the day, that utilization is responsible for a large amount of the cost of the system. And having some ability to identify and tackle that will be a huge cost saving. So care coordination, again, that's the theme. Having people call patients after discharge within 3 days to ensure that they have their medication, did they get their medications? Do they know how to take their medications? Has it been Have they been instructed in the language that they prefer? Do they have a follow-up appointment? Do they know when they need to follow up? What they should be looking for? For the diabetic, they need to be able to check in or sugar. That kind of education is all really new to the system. And tying the financial remuneration to these endpoints is really what we're all trying to get to, which is to become a high-quality, low-cost provider. That's the
Right, I mean, his thesis is, tell me what good care looks like, and then, develop the reimbursement system around that view.
Well, we're working to some degree with his thesis as it relates to collaboration with St. Francis Hospital and Capital Health, specifically the Capital Health, the full campus here in the city of Trenton, and the Federal Qualified Health Center, Henry J. Austin. Several of our zip codes that are impacted in our primary care area come from the Trenton zip codes, and so we have been working with them on a number of issues collaboratively, because a patient that requires this level of care moves from hospital to hospital to hospital consistently, and there are cases of people here in this area that have been in an emergency department 100 times in the course of a year for any number of issues. So we have come together similarly as it relates to Trenton to deal with it similarly as to what Dr. Brenner has done down in Camden. Aside from that, like Ken and St. Peter's with Robert Wood, we also were engaged in a community needs assessment funded by the Robert Wood Johnson Foundation for the balance of Mercer County. And so we meet with every local health agency in terms of the municipalities, as well as with Princeton and Capital Hopewell, all on the same panel. We work together, and we've come to the same conclusions. Behavioral health is a serious issue. Obesity is a serious issue. Looking at Mercer County's rank in terms of the healthcare of the community, it ranks in the mid part of the state. And so by virtue of us all coming together, we're developing programs collaboratively as to how we can manage that population better than what we've been doing up to this point. So it is moving in that direction.
And most people know Virtua does have a location in Camden, and our doctors there are part of the Camden Coalition, so they're participating with Dr. Brenner in his work with the Camden population. But a number of the other things we're doing around, it started with our Accountable Care Organization application, and we developed teams of people working both from within the Virtua Medical Group, which is kind of our testing ground right now, but we're planning to expand our model of care to all of our population over the next few years. And so what we've done is, last summer, we started a different group of transitions of care, quality metrics, patient engagement focus, and also practice redesign for the primary care practices, and trying to improve the efficiencies and support for those practices. And so as an outgrowth of that, now that we know some of the patients who are currently beneficiaries of the Accountable Care Organization, we're looking at risk stratification for those patients and trying to do the similar thing, taking the top 5% in this case and looking at their demographics. And it's been a real challenge trying to figure out exactly which practice they belong to, which doctor is their primary doctor, but then also trying to develop a care coordination model, which we're calling community-based health managers. And again, as Ken said, I think that's really the way of the future, and what Dr. Brenner has really done is heavily case manage those patients that are the biggest utilizers, and patients respond to that because they finally feel somebody's caring about them. And I think that it really has helped him to get some good numbers and start the outcomes.
Yeah, that's it. I mean, that's what he's reporting down there. Now, are your hospitals all part of an ACO?
Robert Wood is in the initial stages of forming an ACO. What we're really doing is bringing physicians together in either an owned practice model or a leased practice model, which are the foundations, the fundamental foundations of an ACO. It's expensive to develop an ACO. These are not, you just don't pull these things together. I mean, the initial costs are somewhere run upwards of $3 million to $4 million to bring it together. And candidly, the complete results aren't, known whether in fact they work. There are more mature ones, but someone said earlier this morning, New Jersey's behind in terms of that the development. So we are on the initial threshold of looking at that. And there are other health systems in the state that are also developing ACOs.
I would echo Skip's comments. What exactly is an ACO or a patient-centered medical home? How large do you have to be defined as an ACO? We have individual physician practices that are part of patient-centered medical home grants and CMS initiatives. So, all it means is it's an accountable care organization. How large or small doesn't make a difference. If you're aligning your physicians in your hospital, that's an ACO. Calling it an official and meeting the specific requirements is another thing. But the goal is managing the care. The other thing I just wanted to point out is we really focus around cost of care here. Two things. One is there was a New York Times article today, actually, that talked about the widely variable costs of various procedures among hospitals, not only across the nation, but even in local regions. The other big part of that is we have so much waste in the system. We talk about disease and we talk about chronic disease and how those cost. But when you look at the totality of the system, the amount of money we spend administering the system, much like the tax code. I mean, if we simplify the tax code, we could save billions of dollars, eliminate a lot of jobs with billions of dollars. The same thing is really in the healthcare system. When you look at, one of the things I was heavily involved in my previous part of the career was in coding and billing and documentation, and the number of the infrastructure in place to make sure that we're coding properly, the resources going to manage the recovery audit contractor responses to take money back from us from 3 years ago is enormous. It's billions and billions, if not more dollars. So at the end of the day, I think we all need to focus on how much of our healthcare, how much of the money spent is actually going towards patient care. So even though the chronic disease part is a waste, there's some wastage in the system, there's so much other money in the system that's not going towards patient care that I think is really, we would be remiss if we didn't at least acknowledge.
So does the Accountable or the Affordable Care Act actually tackle that issue in your mind?
I don't believe so.
No?
I think actually there's more. In fact, there's more money that needs to be for the infrastructure. Even, I don't know how many are familiar with ICD-9 and ICD-10. Other countries have used it, but not for billing purposes. We're moving to the Internal Classification of Diseases version 10, which will exponentially increase the resources required. And I don't know what your organization is doing, and I don't need to take us off base, but the amount of money spent to administer and roll that out is enormous. And it's not going to help necessarily patient care.
That's always my mantra about the ACA, is that it's really been insurance reform. It hasn't really changed the delivery system. The delivery system is changing because of other factors that we all know pretty well about, but it's not really, I think, totally driven by the ACA. And I guess from my own organization, in the health system's point of view, to me it seems like the accountable care organization we developed was really kind of more of an incentive in order to figure out the care coordination and the clinical integration of our clinicians and look at ways to reduce our waste in the system using the lean model that I think we heard one of the speakers in the Medicaid panel talk about. So, I think to me it's really more of a way to get the organizations to figure out how can we kind of free ourselves of the yoke of some of the things that have been put on us by the structures of insurance companies and the government, and how can we take more of that into the system's hands and be able to control our own destiny further. So the accountable care organization and development of ACOs may be just one of the ways to push us towards that.
Okay, so what, aside from the added layer of administration and compliance, and let's face it, the government is going to be very active in healthcare fraud and abuse investigations, enforcement. It's something that's not going to go away. In fact, in many ways, it's a revenue-generating exercise for the government. But from a collaboration, hospital-physician collaboration standpoint, where are the major obstacles, do you think? Short-term, long-term? We've been hearing some pretty good stuff this morning about collaboration. Where are the obstacles?
Well, from the hospital's perspective, I think it is we have to get to a place where the financial incentive between physician and hospital are aligned. So, under the current system, the hospital gets paid for so many days of care, but the physician continues to be paid for care while that patient is in the hospital. That is not a healthy system for us. And so we need to get that kind of alignment that will work. I also think that hospitals and physicians have to collaborate on, and Ken mentioned this earlier, but on chronic disease in a much different way than we have to this point. When you look at heart disease, when you look at stroke, when you look at hypertension, when you look at type 2 diabetes, which is exploding in our country, our costs in the system are $238 billion. Out of the $2.6 trillion we spend in healthcare, 1.9 trillion is spent on chronic disease. And so where we can come up with programs and where we can align those things, I think that will, and everybody talks, and Ken mentioned it earlier, bend the cost curve. You want to bend the cost curve? You bend the cost curve by getting prevention in place, getting wellness in place, and having physicians aligned with hospitals to deliver that in the healthcare system. And then I think we'll see costs come under greater control.
I completely agree, and I think initiative like gain sharing, I don't know if how many are familiar with it, but in the past, there was always, because of Stark laws, anti-kickback statutes, there was a specific law that prevented hospitals from sharing certain profits and monies with physicians because of past indiscretions and so forth and inappropriate relationships. The carve-out for the gain sharing program was a way to say, okay, if the physician does, if the physician's normal length of stay for a severity adjusted case is 5 days, but best practice is 3 days based on the cohort, if the physician can get down to that 3 days, the hospital saves money because their cost of care go down, the length of stay goes down, which is the majority of the cost. The hospital can then share some of that savings with the physician. That is something that's really revolutionary and different and was prevented from the law in the past. So I think that's a huge step towards getting us to the point where we can even talk about alignment of physicians with hospitals.
So I would echo both of your comments. I think you're right on target. I think just to add to some of the discussion would be, I think workforce is the big barrier for us right now. When you think of, again, primary care access challenges, we really need to look at, especially in New Jersey, how do we attract physicians, medical students to become physicians in our state and become primary care physicians in our state especially. But also there's a number of other specialties that we may be lacking in as time goes on with the aging of the physician workforce. And we really have not held the educational institutions accountable, I think, to helping us to develop the kinds of doctors we need. And so I think that's something that we need to do as a state. We need to look at ways, to incent our students with loan repayments to stay in New Jersey and practice here, and again, practice in the kinds of specialties we need and in the right kind of model. So I think that's a barrier and a challenge, an opportunity for us in the future. And I think the other thing is just our health information technology structures and how to, developing structures where all of our institutions will be able to exchange data easily. And I think then once we have those things, which again has been a big challenge just in my own arena, developing the infrastructure of both the electronic health record, the health information exchange, getting the nursing home care, all the different pieces of the puzzle to talk to each other. But then once we have that, it's really having the data to analyze. And I think, I guess I heard a term in the information technology world yesterday, DRIP, where you have data rich but information poor. And it's how do we take the data we have and do things like what Dr. Brenner's doing to really utilize it to extract meaningful information about your population and then correct your strategy to support them and to make them healthier and to have better outcomes. So that's a huge work, and it's going to be going on for a long time, but it's really kind of extending that whole big data concept that I think we're hearing a lot of other industries, like healthcare needs that dramatically right now.
One thing I just wanted to add that I don't think the ACA really addressed. One of the biggest costs that I see is also defensive practice of medicine. And medical malpractice reform, I really think is lacking in some of the statutes that are being proposed, which is a huge driver. It's been multiple documented studies around defensive practice of medicine, adding up the costs, and getting the extra studies that are not evidence-based supported. I think that needs to be addressed as well, in addition to all of it.
Yeah, malpractice reform is not addressed anywhere in the ACA. Okay, we have a couple of minutes left. Let's take out the crystal ball. You know, we're going to look 10, 20 years from now at the New Jersey healthcare marketplace. What does it look like to you?
I think that the marketplace looks like 5 or 6 healthcare systems in the state of New Jersey. I think that over the next decade, you will see a lot of consolidation. With resources being pulled out of the system, there will be a need for far greater collaboration that will go on between within a health system with respect to its buying power, with respect to its clinical integration. So I think the model that we see today will be dramatically different. There's also one other thing I think is going to be important to New Jersey, and while it's being talked about, it's not really being focused on, and that has been the whole integration of the Robert Wood Johnson Medical School and the University of Medicine and Dentistry into Rutgers, which will turn Rutgers, which is an excellent institution in its own right already, but will turn it into a top research university in this country. And I think that the results of that will have a great benefit to New Jerseyans as we move forward in the future. A long time in coming, lots of work to be done, kicks off July 1, all won't happen in the first 6 months, obviously, but clearly it will be something that will be of great benefit to New Jerseyans.
I agree, could not agree more with everything you just said. I will just add that I think hospitals will look very different. Not only will there be a fewer number of them, but what you see in hospitals will look very different. More of the care will be pushed to outpatient settings where it's cheaper. I think that, and you already see ancillary services being done in private offices and moving away from hospitals for those services. The other thing I think, when you look at our pediatric population, I think that's almost a little bit of a predictor to what hospitals might look like with improving health. As over the past 10, 15 years, as vaccinations have improved and pediatric patients who we used to have sepsis, sepsis has kind of been eradicated by some vaccines. When you look at pediatric inpatients today, they're usually sick children. The well children that used to get admitted for basic minor things are no longer in hospitals anymore because they're kept out. And I think you're going to see that patients in hospitals, because of obvious the way things are moving, that will be sicker. You're not going to have a patient with basic cellulitis with no other comorbidities being admitted to hospital. We're seeing that today. So I think that drastically changes the need for these huge, many building hospitals all over the place, and that consolidation will be part of that as well.
Mary, your crystal ball?
Okay, well, I see that there's, some of what you're all saying too, and also just, I think we're going to see conglomerates more, not just health systems, but I think we're going to see, there's all kinds of partnering happening, and we're seeing the pharmacies joining in with accountable care organizations, with physician groups. We will see insurers, I think, kind of blend in and become different kinds of partners. And, I think it's going to consolidate, so there's probably going to be, 5 or 6 at the most different kinds of conglomerates around the state, but they may not be the traditional health systems as we were thinking of them. And I think, things will be based more on population and how is the health of the population that those people take care of, that those institutions take care of. And the physician work, I think, is going to be very, very different in the future. I think already, again, we're starting the development of teams. I think physicians are going to continue to be leaders of teams and distributing their work differently. I hope we never lose the basics of just physical diagnosis, but that I think there'll be a lot more management of data on your population. That will be kind of the physician's role to kind of take the data and figure out the strategies to help their group of diabetics, enhance their wellness and their activation in their care. So, I think it's just going to be a very different world in the future going forward.
I want to make one more prediction. Maybe it may not come true. In addition to consolidation, I think the regionalization of healthcare will also come about. So what that means is even though there might be 5 or 6 conglomerates, they might not all do all the services. So you may, if you need cardiac surgery, you may go to hospital X or system X in middle New Jersey. If you need service Y, you may go to a different place. It's not that every hospital will be everything to all people.
Well, it's going to be a fun ride, there's no question about it. Skip, Ken, Mary, thank you very much for your thoughtful, sharing your thoughts, your thoughtful analysis. Thank you for having us.
Thank you.
I think all of our panels, all of our moderators have done terrific jobs this morning. John Sarno as well, Linda Schwimmer, Jim Robertson, thank you so much. And to our fabulous panelists. I think, as I said, and I don't have the luxury of sitting and listening as I'm up and around a lot, that's one of the reasons we videotape this, and someone asked about the video. It will be posted on our website within a week or so. Our website is statepublicaffairs.org, so you'll be able to review the proceedings and let people know who perhaps weren't here today, that they can come back and view these again. My sense is that while there's certainly a great deal of work to do, so many changes have already been taking place that our healthcare system is essentially changed in many ways. And the official start, I guess, in October with the exchange, and as things take place in 2014, there's really been a lot of preparation and readiness. We might be readier than we think we are, even though there's still a lot of work to do. So thank you so much for your insights this morning. Thanks for being here. Drive safely on the way home. Don't forget your free passes to the Health and Wellness Center. Thanks to our sponsors. And thank you all for joining us today at State of Health.